You know, usually when you walk into a clinic with some kind of medical problem, there's this expectation of mechanical precision, I guess.
Oh, absolutely. Yeah.
Like, you fall, your arm hurts, the doctor orders an x-ray, and boom, there's a jagged white line on the film. The diagnosis is totally binary.
Right. It's broken or it's not.
Exactly. You put a cast on it and you go home. It's simple.
And, it is incredibly comforting for both the clinician and the patient to have that kind of visual certainty. I mean,
Yeah.
we inherently want our biology to be easily categorized like that.
We really do. But the moment you step out of the emergency room and into, say, the gastroenterology or pathology departments, that neat binary x-ray machine, it shatters.
Yes, it completely falls apart.
Right. Because if you are dealing with chronic gut or throat issues, you are navigating a diagnostic landscape that is just incredibly murky. And that is actually our mission today for this custom-tailored deep dive. We are exploring one of the most complex medical challenges hiding in those muddy waters.
It's a fascinating one, too.
It really is. Basically, we're looking at how clinicians evaluate sub-epithelial fibrosis versus active inflammatory mucosal thinning. Or, in plain English, how do doctors distinguish between a tissue that is currently burning with active inflammation and a tissue that has already turned to cold, hard scar tissue?
And I should point out, this isn't just an academic exercise either. Why you, as a listener, should care about this is because the stakes are huge.
Yeah, the treatments are totally different, right?
Exactly. Whether we are looking at Crohn's disease in the small intestine or eosinophilic esophagitis, which we call EOE, in the throat, or oral submucous fibrosis in the mouth, the stakes for getting this right are immense.
Because the pathways just diverge completely based on the cellular level.
Right. So if a stricture and narrowing in your throat is caused by active inflammation, meaning the tissue is swelling with fluid and immune cells, medications like steroids can calm that immune response down.
You can basically put out the fire.
Precisely. But if that tissue has already undergone permanent remodeling, if it's turned into dense fibrotic collagen, throwing pills at it won't do much, you have to physically intervene.
Like physically stretch it out.
Yeah, perhaps by dilating the esophagus with a balloon.
Right.
Or even performing surgery to resect a piece of the bowel.
Man. So if you misdiagnose one for the other, you are looking at failed treatments, unnecessary surgeries, and in the case of oral submucous fibrosis, a high potential for a malignant transformation into oral cancer.
It's a very dangerous situation.
But the core problem across all these diseases, as I understand from the sources we're looking at today, is this grand illusion that happens on the surface.
The surface illusion, yes.
Right. The very top layer of our internal lining, the epithelium or the mucosa, it often becomes dangerously thin and atrophic. But peering at that thin surface doesn't tell a doctor what is happening underneath it.
It's a classic misdirection.
Yeah.
To really understand how we eventually look beneath that surface, we have to grasp why the surface layer is so inherently deceitful in the first place.
Okay, lay it on me.
So if we picture the mucosa, that delicate lining of your throat or mouth, think of it like a lawn of grass.
Okay, a lawn. Got it.
You look out the window, and the grass is thinning, dying, it's patchy. That is our epithelial atrophy. But the critical question is the actual mechanism of that death.
Right, like why is it dying?
Exactly. Is the grass dying because a brush fire is currently sweeping across the surface? Or is it dying because the soil underneath has turned into an impenetrable slab of concrete, which is suffocating the roots?
Oh, that is a great way to think about it. And I actually noticed in the research on GE, or gastroesophageal reflux disease, it's very clearly the brush fire scenario.
Yes, very much so.
Because stomach acid is splashing up into the esophagus and physically burning the surface cells. The acid denudes the epithelium from the outside in.
It's a direct external assault.
Right. And when pathologists look at those surface squamous cells, they see things like nuclear hyperchromatism and atypia. Basically, the nuclei of these cells become abnormally dark and enlarged because the DNA is working overtime, desperately trying to repair the relentless chemical burns.
The damage is entirely top-down. But if we contrast that with oral submucous fibrosis, or OSMF, the entire mechanism is inverted.
It's the concrete soil scenario.
Exactly. OSMF is heavily linked to chewing areca nut.
Right, the areca nut.
Yeah, so when someone chews areca nut, the alkaloids in the nut seep into the tissue and directly trigger the fibroblasts.
And those are like the builder cells, right?
Builder cells, yes, and the deeper layer called the lamina propria. Those fibroblasts just go into absolute overdrive, pumping out massive amounts of extracellular matrix. The soil beneath the surface becomes choked with thick, dense bundles of collagen.
So it's literally turning the deep tissue into concrete.
It really is. And as that collagen builds up, it physically constricts the local blood vessels. The blood supply is choked off, the tissue loses all its elasticity.
Which means the surface cells get starved.
Precisely. The epithelial cells sitting on top of this mess are starved of nutrients. So they stretch out, they lose their structure, and they become thin and atrophic.
Wow.
Yeah, the thinning of the surface is a secondary reaction to the disaster happening below.
So to the naked eye, or even under a basic scope, the surface looks identically damaged in both diseases, but the root cause couldn't be more different.
Exactly.
Which leads to the obvious mechanical solution, right? Like, if you're a doctor and you know the problem might be in the soil, you shouldn't just scrape the grass. You need to dig a deeper hole and take a deep tissue biopsy to see the concrete.
It is the logical next step. But getting that deep sample represents a massive, massive hurdle.
Really, why is it so hard to just take a deeper cut?
Well, the sources tracking EOE, eosinophilic esophagitis, provide some pretty startling data regarding this blind spot. When a gastroenterologist goes in with standard biopsy forceps to grab a sample of the esophageal wall, they only manage to capture adequate sub-epithelial tissue about 37 to 50% of the time.
Wait, really? Meaning more than half the time they are only getting the grass?
More than half the time, yes.
It's wild. But I guess I can imagine there's a physical reason for that. If the underlying tissue really has turned into dense, rigid collagen, those tiny little biopsy jaws probably just slide right off the hard surface, without biting deep enough.
That is a significant part of the mechanical failure, yeah. The forceps just skip off the concrete.
So what do they do?
Well, clinicians can use larger, specialized static jaw forceps. Those bite much deeper, and they can increase the yield of sub-epithelial tissue to over 90%.
Oh, well, that sounds like a fix.
It is, but they are more invasive, they carry a much higher risk of bleeding, and they just aren't practical in every clinical setting.
I see.
Furthermore, the studies reveal a truly terrifying disconnect. You might assume that counting the number of inflammatory cells like eosinophils on whatever surface tissue you do manage to scrape would give you a clue about the depth of the disease.
Right, like if there's a lot of inflammation on top, there must be a lot underneath.
You'd think so. But the data shows those surface counts only modestly correlate with the deep tissue reality.
Oh, wow. So you could have a surface that looks relatively calm under a microscope, completely masking a rigid fibrotic disaster in the muscularis propria down below.
Exactly, which means a shallow biopsy can give a doctor a very dangerous false sense of security.
Okay, so let's unpack this a bit more. Assuming the doctor does manage to wrestle a good, deep chunk of tissue out of the patient using those larger forceps, what happens next? If a pathologist is staring at a slide in a lab, how do they definitively prove that the tissue remodeling has crossed the line from reversible swelling into permanent concrete?
This is where the pathologist's toolkit becomes fascinatingly precise. They aren't just, guessing based on how thick the tissue looks. They're using structural chemistry.
Okay, I love this part.
Yeah, the gold standard for quantifying fibrosis is a specific histological stain called picrocereus red, or PSR.
PSR, right. And the magic of PSR, from what I was reading, isn't just the dye itself, it's how it reacts with polarized light.
Right, exactly. The dye molecules align parallel to the collagen fibers.
So when a pathologist shines polarized light through the slide, the collagen essentially becomes birefringent, it glows.
It does.
But what's incredible to me is that it color codes the severity of the scar tissue based on the physical thickness of the fibers.
It really is elegant. It translates microscopic density into a vivid visual spectrum. Under that polarized light, thin, newly formed, delicate collagen fibers appear green or yellow.
Okay, so green is new.
Right. But the thick, tightly packed, mature fibrotic bundles, the advanced concrete, they glow a brilliant red. It allows the pathologist to objectively quantify exactly how much of the tissue has permanently remodeled.
That is so cool. But they don't stop at just coloring the collagen either. I was reading about morphometric analysis in the OSMF studies, and they are measuring the physical deformation of the cells themselves.
Yes, the cellular geometry.
Right, because if the tissue underneath is hardening and creating mechanical tension, it physically distorts the basal cells sitting on top of it.
We see that very clearly in the data. Pathologists measure the dimensions of these cells, calculating their roundness and something they call the contour index.
Contour index.
Yeah, and as the fibrosis worsens and the collagen tightens, the cells physically deviate from their normal shapes. They are stretched and squished by the tension beneath them.
Man, so it adds a mathematical geometric layer of proof to the diagnosis.
Exactly. And there's another highly specific diagnostic fingerprint mentioned in the sources, particularly regarding strictures caused by prior radiation therapy.
Oh, right, for cancer patients.
Right. If a patient had radiation, the resulting fibrosis looks entirely different from standard scarring. The pathologist hunts for atypical radiation fibroblasts, these bizarre enlarged cells with mutated nuclei.
They actually call them bizarre.
They do, and they look for something called fibrinous exudate.
Fibrin exudate, which is, I mean, it's essentially a delicate microscopic web of acidophilic fibrils, right? Protein fibers leaking from chronically damaged blood vessels trapped within the collagen matrix.
Spot on. You just don't see that in run-of-the-mill inflammatory scarring. It's a permanent marker of radiation injury.
It is incredibly elegant science. I mean, staining collagen to glow red, measuring the geometric stretching of a cell, hunting for the fingerprint of radiation. It's amazing. But we have to acknowledge the fatal flaw in all of this.
The invasive nature of it.
Right.
Yeah.
It requires cutting a piece out of a living human being. It's invasive. It often misses the deep tissue like we talked about. And most importantly, it is a dead, static snapshot.
That is the crux of the issue. A biopsy under a microscope cannot tell you how that tissue actually behaves when the patient tries to swallow a piece of chicken.
Yes, exactly. Taking a biopsy is it's like trying to check a bicycle tire by cutting a tiny square of the rubber out and looking at it under a magnifying glass.
That is a perfect analogy.
I might see the rubber is degraded, but that's not how you test a tire. You pump it full of air and see if it expands properly and where the wall fails to hold pressure.
Right.
We need a way to measure the organ's physical mechanics while it's still inside the body.
And that exact requirement led to one of the most vital technological leaps in this field, impedance planimetry.
Impedance planimetry.
Yes, or more commonly, clinicians use a functional luminal imaging probe.
FLIP.
Exactly, FLIP or endoflip, which is heavily utilized in evaluating EOE.
The mechanics of this balloon probe are just brilliant.
They really are.
During an endoscopy, they slide an uninflated balloon catheter down into the esophagus. They fill the balloon with a conductive fluid, and the catheter has multiple electrodes running through it.
Right.
And by passing a tiny electrical current between the electrodes through the fluid, they can calculate the exact cross-sectional area of the esophagus relative to the pressure being pumped into the balloon.
It's amazing. It essentially builds a real-time 3D geometric wireframe of the inside of the throat as it stretches. It is continuously feeling how hard the esophageal walls are pushing back against the fluid.
And the vital metric it spits out is the distensibility plateau, or the DP.
The DP, yes.
This is the absolute limit. It's the point where no matter how much more pressure the balloon exerts, the esophagus refuses to stretch another millimeter.
And the clinical cutoffs here are quite stark. The data shows that if a patient's distensibility plateau is under 17 millimeters, or if the cross-sectional area is under 225 millimeters squared, the tissue has severe fibrotic remodeling.
A 17-millimeter pipe. That is tiny. That is smaller than a lot of the food we swallow on a daily basis.
It is.
It perfectly explains why these patients are at such a high, terrifying risk for food impaction, where they literally get food stuck in their chest. The concrete simply will not yield.
It won't. But, and this is where it gets really interesting, the endoflip data also provided a massive paradigm shift in how we understand the relationship between inflammation and fibrosis.
Oh, yeah, this blew my mind.
Right. For a very long time, medical consensus assumed that once tissue remodeled into that dense fibrotic scar, it was a permanent one-way street. The concrete was poured and set. Game over. Game over. But the balloon showed that wasn't entirely true. The research demonstrates that if you treat the active inflammation in EOE patients with swallowed topical steroids, like budesonide, you don't just put out the inflammatory fire.
Over time, the actual distensibility of the tissue improves.
Exactly. The plateau expands. By chemically shutting down the inflammatory signaling cascade, the steroids somehow allow the fibrotic tissue to soften. The esophagus becomes less stiff.
That is just incredible.
It proves that inflammation and fibrosis are not just two isolated events, but a dynamic, interconnected feedback loop. Disrupt the inflammation, and you can partially reverse the structural stiffness.
That is such incredible news for a patient with a throat stricture. But if we expand our view a bit, An endo-flip balloon is highly effective for a relatively straight, accessible tube like the esophagus, right?
Sure.
What if the stricture is hiding deep inside the 20 feet of twisted, winding small intestine like we see in patients with Crohn's disease? You cannot thread a pressure balloon through the entire digestive tract.
No, you absolutely cannot.
So we are forced to look through the abdominal wall using external radiological imaging.
Which introduces an entirely new set of physical limitations. Now, standard imaging, like a routine CT scan, is phenomenal at showing a doctor where the bowel wall is thickened.
Right, like finding the swollen spot.
Exactly. A healthy small bowel wall is remarkably thin. If it swells past 3 millimeters, that's abnormal. If a CT scan shows a segment of bowel that is 2 centimeters thick, the radiologist can easily flag the blockage.
But we are right back to the core mystery, aren't we?
We are.
We know it's 2 centimeters thick, but why is it thick? Is that wall engorged with soft, fluid-filled inflammatory edema? Or is it packed solid with fibrotic collagen? A standard CT scan just sees a thick gray shadow.
That's the problem. And if a surgeon operates and removes a bowel segment that was actually just swollen and could have been treated with steroids, well, they've subjected the patient to an entirely unnecessary life-altering surgery.
Which is why the field is aggressively pursuing elastography, specifically shear wave elastography, or SWE.
Yes. The concept here is to use external sound waves to remotely palpate the organ.
The physics here are just fascinating. If you think about plucking a loose guitar string, the vibration wave travels slowly down the string. But if you tighten the tuning peg and increase the tension on the string, the wave travels much faster.
Exactly.
SWE operates on the exact same principle. It shoots an acoustic pulse into the body, creating shear waves that ripple horizontally through the intestinal wall. The ultrasound then measures how fast those waves propagate.
And because sound waves travel faster through dense, hard materials than soft ones, the speed of the wave directly correlates with the stiffness of the tissue.
That makes total sense.
It really does. SWE provides a quantitative measurement in kilopascals, or kPa, and it actually generates a visual color map over the ultrasound image.
Oh, a color map.
Yeah, so homogeneous blue typically indicates rigid fibrotic tissue, while green indicates softer inflamed tissue.
Okay, it sounds like the Holy Grail. The doctor waves an ultrasound wand over your stomach, reads the kilopascals, sees the blue color, and instantly knows it's fibrosis.
It does sound perfect.
And some of the studies in the sources back this up heavily, right? Researchers like Zhang and Chen found SW to be highly accurate. Chen identified a specific cutoff of 22.55 kPa to discriminate between mild and severe fibrosis.
Right.
And Zhang found a similar cutoff of 21.30 kPa and noted that combining this shear wave data with a CT scan resulted in over 94% specificity for diagnosing severe fibrosis.
Those numbers are incredibly promising. However, and this is a big however, we have to look at the conflicting data from other researchers, like Alaka and De Cristofaro.
Okay, what did they find?
Well, they conducted independent studies where they measured the intestinal stiffness of Crohn's patients using ultrasound elastography. And then they directly compared those kPa readings to the actual collagen content in the surgical specimens removed from those same patients a few days later.
Okay, comparing apples to apples.
Exactly. And they found absolutely no significant correlation between the ultrasound stiffness and the actual microscopic fibrosis.
None. Wait, really?
None. The patients with high kPa readings did not consistently have higher collagen levels under the microscope.
Wow. So we have a stark division here. One camp is reporting 94% specificity, and another is reporting zero correlation.
Yep.
And honestly, if we think about the mechanics of an ultrasound, it's easy to hypothesize why this debate exists. To measure a bowel deep inside a patient, that sound wave has to successfully travel through the skin, the abdominal muscles, and layers of subcutaneous fat.
Right, and fat absorbs ultrasound waves.
Exactly. Then, if there is any intestinal gas in the way, the gas completely scatters the sound. So if a patient has a higher body mass index or a lot of bowel gas, that shear wave might be heavily distorted before it ever touches the stricture.
That is a massive factor. Furthermore, Crohn's disease is notoriously patchy. The inflammation and fibrosis can be transmural, meaning it affects the entire thickness of the wall, but it might be heavily concentrated in one localized spot and completely absent an inch away.
Oh, so if the wand hits the wrong spot?
Right. If the ultrasound wand measures one specific inch of the bowel through the skin, but the surgeon later resects a 3-inch section, and the pathologist slices a slightly different centimeter to look at under the microscope.
They aren't comparing apples to apples anymore.
Exactly. The methodology is incredibly vulnerable to sampling error.
Makes sense. Because of that unreliability, many clinicians turn to magnets instead of sound, specifically MRE, or magnetic resonance spectroscopy.
Yes. MRE is deeply embedded in Crohn's management, but it's the specific way radiologists manipulate the magnetic resonance that makes it so valuable.
Right.
They utilize T2-weighted sequences with a crucial addition: fat saturation.
We have to unpack the physics of that because it is genius.
It really is.
In a standard T2 MRI sequence, both water and fat return a bright, hyperintense white signal. So if a radiologist looks at a bowel wall and sees a glowing white mass, they have a problem. Is it bright because the tissue is flooded with water, indicating acute inflammatory edema? Or is it bright because it's full of fat?
And in the context of Crohn's disease, the presence of fat in the bowel wall is a hallmark of chronic, long-standing damage. Over years of injury and repair, fat cells actually creep into the layers of the intestine and surround it.
And they call that the fat halo sign, right?
Yes, the fat halo sign.
So if a clinician just looks at a standard MRI, they might see that bright white fat halo, mistake it for raging, waterlogged inflammation, and aggressively prescribe immunosuppressants or steroids to put out a fire that burned out years ago.
Which is obviously very bad. So, to prevent that, the radiologist applies a fat saturation pulse to the MRI sequence. This radiofrequency pulse is tuned to the exact resonant frequency of fat protons.
Oh, that is so cool.
Yeah, it essentially knocks out their signal, muting all the fat on the image, turning it dark.
Leaving only the water to glow.
Exactly.
So if the bowel wall is still glowing bright white after you saturate and hide the fat, with absolute biochemical certainty that you are looking at edema, you are looking at an active inflammatory fire.
It allows clinicians to confidently peer through the complex layers of chronic damage and isolate the active, treatable inflammation.
When you pull all these threads together, the sheer scale of the ingenuity is staggering.
It really is.
I mean, we started this deep dive acknowledging that the surface of the tissue, the thinning, starving epithelium, is a grand illusion that masks the true nature of the disease. We had to dig beneath the surface. And when biopsies proved unreliable, pathologists turned to polarized light to color code the thickness of collagen fibers and geometrically measure the microscopic stretching of basal cells.
But when we realized we couldn't rely solely on dead, static tissue, we pumped fluid into impedance balloons to map the biomechanical failure of the esophagus, discovering that treating the fire can actually soften the concrete.
Right. And for the unreachable depths of the small intestine, we moved to physics. Bouncing shear waves off the bowel to measure its acoustic tension, and manipulating magnetic resonance to mute the signal of chronic fat, leaving only the glowing signature of active inflammatory water.
We have transitioned from merely looking at the shape of an organ to mechanically and molecularly interrogating its structural integrity.
Absolutely.
But, as we look at the trajectory of this research, we are approaching a horizon that might render much of this physical probing obsolete.
Okay, yes. The sources outline the early stages of researchers integrating artificial intelligence and web-based predictive models into this diagnostic workflow. And their approach is completely counterintuitive to everything we've just discussed.
Completely opposite.
Instead of trying to find better ways to dig deeper, they are training AI to look only at the superficial data from a standard, shallow biopsy.
Right. They are feeding the algorithms data on subtle surface alterations, like the presence of dyskeratotic cells.
And those are superficial skin cells that are undergoing premature abnormal keratinization and death on the surface, right?
Yes. Historically, we view these surface changes as unhelpful noise, just secondary reactions that distracted from the deep tissue.
But the AI is recognizing massive, complex patterns in that noise. It is learning to correlate the specific type of distress on the surface with the exact degree of sub-epithelial fibrosis hidden underneath.
Incredible.
It's analyzing the dying grass to perfectly predict the density of the concrete without ever having to dig into the soil.
It leverages computational power to reconnect the surface to the depths, bypassing the physical limitations of our instruments entirely.
Which leaves you with an incredibly provocative thought to mull over as we wrap up this deep dive. If an AI model can predict profound structural changes in the deep tissue simply by analyzing the subtle distress patterns on the surface epithelium, What happens when camera technology catches up?
Oh, that's a wild thought.
Right. Could we eventually reach a point where a patient simply swallows a smart camera pill and the optical sensor reads the visual topography of the tissue as it glides by, instantly diagnosing the exact level of deep fibrosis based purely on the visual texture of the surface?
It's entirely possible.
No biopsies, no balloons, no sound waves, just a machine learning algorithm reading the surface of your body like a topographical map, finally revealing the deepest secrets hidden underneath.